Hello everyone, this is Dr. Suraj. Today we'll be talking about placenta previa and various managements of placenta previa. So let's get started. What is placenta previa, guys? Placenta previa means here the mother will be presented to you with bleeding in the late trimester. So in the third trimester or in the late pregnancy, the mother will be presented to you bleeding. Now, this bleeding is very characteristic because we had just a discussion about abruptio placenta, and there I told you that abruptio placenta cup bleeding is painful bleeding. Okay, painful bleeding, and there was a history of trauma to abdomen or pelvis. So antenatal trauma to abdomen and pelvis, this are the typical history, and this is a very painful condition, abruptio. But this is not in the case of placenta previa. Here the bleeding is typically painless, it is causeless, and as it is causeless, this bleeding is recurrent in nature. So many times it is associated with warning hemorrhages. Okay, so the main important point is there is no pain abdomen that is associated with bleeding, which in case of abruptio that is present. Now there is a classification system for placenta previa, which is like the placenta is there and the margin of the placenta, if it is within 2 centimeter of the internal os, that is what is known as lateral previa. That was previously known as lateral previa, but now it is known as low lying placenta. Now it is known as low lying placenta. Okay, and anything where the margin of the placenta either just touches the internal os, or it is just partially covering the internal os, or it is completely covering the internal os, are now known as placenta previa. See the new classification here is the new classification system: low lying placenta where old type 1 less than 2 centimeter, and placenta previa old type 2, 3, 4, that is where the placental edge either reaching up till the os or covering it. Okay, so either the marginal variety or partial previa or complete previa is now known as placenta previa. Okay, now very important thing that you have to know regarding the examination of the placenta previa. Okay, because this is very important and we have to know what are the differences from the abruptio placenta. In abruptio, I told you the uterus is rigid, very tender, and because the uterus was very much rigid, the fetal heart sounds cannot be easily accessible. That was not here. But here in case of previa, the uterus is soft and relaxed, and that is non-tender, and because of that the fetal heart sound can be easily heard and the fetal parts can be easily felt. But these are all actually opposite in case of abruptio placenta. Okay, one important question, that is malpresentation, which is seen in case of previa, is transverse lie, that is most common. Okay, as the placenta is just touching the internal os, or it is in close vicinity of the internal os, so the pervaginal examination or any kind of instrumentation is contraindicated in case of placenta previa. That is very important. But the transvaginal sonography is not a contraindication. You might ask that in transvaginal sonography the probe is kept inside the vagina, so why it is not a contraindication? Why it is not a contraindication? Because the probe is not near the internal os, it is much away from the internal os. That is not a contraindication. In fact, the transvaginal sonography is investigation of choice because it can correlate, or it can give you the details of the relation of internal os and placental margin. But the screening is by transabdominal ultrasound. Why? Because USG is done to confirm the placenta previa. It is done to confirm the placenta previa. Okay, and as I told you, it detects the malpresentation. And also it rule out the accreta spectrum. Why? Because supposing the mother had a previous LSCS, so mother had a history of previous LSCS or any uterine surgery. So in that case what happens? In this case the placental villi may invade the myometrium, and results in accreta. Management will be entirely changed according to placental accreta spectrum. So to confirm the diagnosis, to detect malpresentation or to detect any kind of accreta spectrum present or not, this is very important. We have to do transabdominal ultrasound. And when to do, the best time is 32 weeks and 36 weeks, because placenta previa may, I told you, the bleeding happens in the late trimester, that is in the third trimester. So we'll be doing 32 weeks and 36 weeks transabdominal ultrasound or transvaginal ultrasound. Okay. Now, how are we going to manage the case of placenta previa? That is very important. So we have two cases, two conditions. Number one condition, where the placenta previa is detected antenatally, so that was an incidental finding. Another, where actually the placenta previa is symptomatic and the patient is presented to you with bleeding. So how are you going to manage the both cases? So first, coming to the case 1, where the patient was diagnosed incidentally with placenta previa on label 2 USG at around 20 weeks. So as we all know that the placenta is present in the lower uterine segment at 20 weeks, but as the gestation will advance, the lower uterine segment will form and there will be placental migration. That means the placenta will be migrated towards upside because of the formation of the lower uterine segment. Okay, because of the formation of the lower uterine segment, the placenta will be migrated to the upper uterine segment. So many cases, around 90% of cases, because of placental migration, that incidental placental previa will not be present on third trimester scans. But even if at 36 weeks of USG, if you find that still the placenta present in the lower uterine segment or placenta previa is present, then we have to do elective cesarean section. Please remember. So we have to do an elective cesarean section at 36 weeks to 37 weeks. Please remember this thing. So whenever you find placenta previa at 20 weeks or incidentally the placenta previa is detected, then give advice that do not do heavy lifting of weight. Okay, don't stand for long time, that is more than equals to 4 hours. Do not stand for more than equals to 4 hours, and avoid medium to severe exercise, and very important, avoid intercourse. So this will be the advice for the mother who was incidentally detected with placenta previa, and you have to plan elective cesarean section for the mother if still at 36th week of gestation she is still having placenta previa. But what if the mother presented with bleeding? So there you have to assess a few things. Now, like first, whether the mother is hemodynamically stable or unstable. Okay, if the mother is hemodynamically unstable or because of severe blood loss, what I told, because of severe blood loss or persistent blood loss, okay, the fetus is also in distress and you find category 3 CTG findings. Okay, or if the patient is in labor, okay, in these cases you have to go for active management. Very important, you cannot wait for anything. Okay, you cannot wait for anything. Even the severe blood loss has occurred and the gestational age is more than 34, this is very important. You can go for immediate C-sections, that is immediate termination of pregnancy by cesarean sections, obviously after resuscitating the mother. So first you will stabilize the mother, then you will go for immediate termination of pregnancy by C-section. Please remember, no vaginal delivery, it's C-section. Okay, next, if the mother is hemodynamically stable or there is no active bleeding or the fetus is okay, that means there is no fetal distress, and very important, if the gestational age is less than 34 weeks, that means the fetus is premature. So that is one condition. Or if the gestational age is more than 34 weeks with not significant blood loss, in that case only we can go for expectant management. Understanding? So if there is significant blood loss, then I have to go for active management. If there is not significant blood loss or no distress, now here we do expectant management, which is McAfee's and Johnson's regime, where we give corticosteroids for fetal lung maturity if the baby is less than 34 weeks. Also, to inhibit the premature contraction, uterine contraction, we can give short-term tocolytics, that is given again in less than 34 weeks. In case of Rh negative pregnancies, we can give anti-RHDs within 48 hours. Within 48 hours. Then we will be carrying the pregnancy and do the cesarean section at 37 weeks. At 37 weeks. So here all these things we have to do after admitting the patient. So this you have to admit the patient and follow the McAfee's and Johnson's regime. This is what is expectant management. So just remember कि expectant management means either the mother is stable or the baby is stable or the blood loss is not that much significant. Okay, whenever it needs resuscitation either for baby or mother, we have to go for active management. Okay, now one important point to add here is what is Stallworthy's sign. Stallworthy's sign means it is on pressing the head down into the pelvis, there will be slowing of fetal heart rate, but when you release the pressure, there will be recovery of the fetal heart rate, basically seen in posterior placenta previa.